Propaedeutics of internal diseases, says Professor Ostap Jaworski, is not only the cornerstone of clinical medicine, but also teaches future physicians the methods of diagnostics. Thus, the synonym of propaedeutics of internal diseases is fundamentals of internal medicine. Clinical methods of investigation, which should be mastered by students in the course of propaedeutics of internal diseases, are as follows: interviewing and examination of the patients, palpation, percussion, and auscultation. This serves as the fundamentals for establishing the preliminary, clinical, and in many cases, the definite final diagnosis. Today, in establishing the diagnosis of diseases, instrumental methods play a significant role. There are electrocardiography, X-ray diagnostics, ultrasonography, computed tomography, magnetic resonance imaging, etc. These and other instrumental methods are used to decide and verify the diagnosis definitively. However, it is necessary to stress that examination of every patient should start with clinical methods, which must be mastered by every physician, irrespective of his or her specialization. Not undermining the role of instrumental methods of investigation, one needs to remember that electrocardiography cannot register pain in a patient. X-ray examination by no means can reveal the crepitation in the initial stage of lobar pneumonia. Neither can computed tomography replace the feeling of palpatory touch. Respiratory system. Palpation of the chest. Palpation of the chest is used for detection of painful areas, evaluation of the intensity of vocal fremitus, and estimation of the elasticity of the chest. For detection of painful areas, the examiner supports the patient from the back with his left hand, while the right hand presses the symmetrical areas of the chest wall and asks the patient about any painful sensation. The examiner asks the patient to turn his back towards him. For evaluation of the vocal fremitus, ask the patient to say some words. In case of Ukrainian language, which contain the sound r, for example, 33. In case of English language, any other phrase can be chosen, for example, 99 or 22. And the examiner evaluates the vibration of the chest, which arises at the same time. During evaluation of vocal fremitus on the anterior chest wall, the patient's arms are placed downwards as shown. For evaluation of vocal fremitus in the axillary area, ask the patient to place his arms on the waist like this. When evaluating the vocal fremitus on the posterior chest wall, the patient's arms are placed slightly crossed in front and his head bent forward. In this position, we can determine the vibration above the scapula, between the scapulae, and below them. For estimation of elasticity of the chest, at first, press in the anterior-posterior direction, then from the sides. This method is less informative because the elasticity, which is determined in such way, depends only slightly on the elasticity of the lung tissue. Percussion of the lungs. In the year 1761, the Austrian physician Auenbrugger proposed and described the method of percussion. The son of an inn owner, aspired to be a physician, watched his father estimating the level of wine in the barrel by knocking on it. This has become the basis of the percussion method, which is still valid today. There are several different types of percussion tones. Two of them are the basic ones. Dull percussion tone is produced during the percussion of absolute Ehlers organs, for example, the liver. This tone is high, short, and thud-like. Tympanic tone is produced during the percussion of hollow organs, for example, on the sides of the abdomen or in hollow areas such as the gastric bubble. Tympanic tone is loud, long, and drum-like. Its pitch depends on the degree of tension of the surrounding organs and cavity-limiting organs. Between the two basic tones, there are three other tones. The resonant tone of the lung is loud, long, and low. There are also flat and hyperresonant tones. While carrying out percussion, it is necessary to follow some rules. Firstly, the pleximeter finger, that is the left middle finger of the examiner in right-handed persons, must be firmly pressed to the body of the patient. Otherwise, the percussion tone will not be distinct and will not reveal the real condition of the tissue. Secondly, movement of the right hand must be carried out only at the wrist joint, and the forearm remains fixed. In the past, physicians performed percussion by using a tendon hammer knocking against a plate made of metal or ivory. However, today, no one uses this method anymore, but percusses using the finger-to-finger method. There are two types of lung percussion, comparative and topographical. The purpose of comparative percussion is the evaluation of the character of percussion tone. One way of comparative percussion is alternating right and left side positions. The examiner faces the patient and asks him to turn his head slightly to the side and percusses as shown. This method of percussion ensures an equal distance between percussion points on the right and left hemithoraces. Initially, percuss anteriorly above the clavicle, later on the clavicle. In this case, the clavicle serves as the pleximeter, in turn on the right and left mid-clavicular lines until we reach the third intercostal space. On the right side, percuss until a dull tone. During percussion on the mid-axillary line, ask the patient to place his hands on his head. While percussing the posterior wall, ask the patient to bend his head slightly and cross his arms in front. Percuss above the scapulae, between the scapulae, and below them. Normally, we hear a resonant tone above all the areas of the lungs. Topographical percussion includes determination of the upper borders of the lungs anteriorly and posteriorly, lower borders of the lungs, and the excursion, that is, the mobility of the lower borders. It is important to remember that markings must be made on the side of the pleximeter finger facing the starting point of percussion. Determination of the lung apex anteriorly. Place the pleximeter finger above the clavicle and percuss upwards parallelly to the clavicle. Ask the patient to turn. Place the pleximeter finger above the spine of scapula and percuss upwards in the direction of the hairline. Measure the height of the lung apex anteriorly above the clavicle. Normally, it is 3 to 4 centimeters above the clavicle. The height of the lung apex posteriorly is approximately at the level of the spinous process of the 7th cervical vertebra. And now, we estimate the lower borders of the lungs. Initially, on the right side, on the parasternal line. Normally, the lower border is located on the lower edge of the 5th rib. On the mid-clavicular line, it is on the lower edge of the 6th rib. On the anterior axillary line, on the lower edge of the 7th rib. On middle axillary line, the lower edge of the 8th rib. On posterior axillary line, the lower edge of the 9th rib. On the scapular line, the landmark is the angle of the scapula, which covers the 7th rib. The lower border is on the level of the upper edge of the 10th rib. On the paravertebral line, the landmark is the 7th cervical vertebra, and from its spinous process we go downwards. Normally, the lower border is on the level of the spinous process of the 11th thoracic vertebra. Now, we estimate the lower border of the left lung. Initially, on the parasternal line. Normally, it is located on the lower edge of the 4th rib. We do not estimate the lower border on the left midclavicular and left anterior axillary lines because it is hindered by the tympanic tone from the semilunar space of Traub. Next, we estimate the lower borders on the corresponding lines as in the right side. Now, we estimate the mobility of the lower borders of the lungs. Usually, we perform this either on the posterior axillary line or the scapular line. Ask the patient to take a deep breath and hold it. From the lower border of the lung, percuss downwards until a dull tone. Later, after a few calm respiratory movements, ask the patient to make a maximum expiration and hold it. Percuss again from the predetermined lower border of the lung upwards until a resonant tone. Place a marking on the lower edge of the pleximeter finger. Measure the distance between the levels at which the tone change occurs. Now, on the left side, ask the patient to take a deep breath and hold it. Percuss downwards until a dull tone. Make a marking on the upper edge of the pleximeter finger. Later, ask the patient to make a maximum expiration and hold it. Percuss upwards until resonant tone. Place a marking on the lower edge of the pleximeter finger. Measure the distance between the lower border of the lung during inspiration and expiration. Auscultation of the lungs. We auscultate the lungs at the points of comparative percussion. Ask the patient to breathe with moderate depth with half-opened mouth. Usually, to obtain optimal result, auscultate the patient in the sitting position. Auscultating in the standing position is not preferred because deep breathing may cause hyperventilation and result in dizziness. To recognize adventitious breathing sounds such as crackles and crepitation, ask the patient to breathe deeper with half-opened mouth. While to listen to basic breathing sounds, that is vesicular or bronchial breathing, ask the patient to breathe with moderate depth through the nose with his mouth closed.
Пацієнту пропонуємо дихати глибше, напіввідкритим. А для того, щоб оцінити основний тип дихання, тобто реальний, дихання, Пацієнт дихає через ніс закритим.
Bronchophony. Bronchophony is the auscultation of whispered sounds on the previously shown auscultation points. Ask the patient to whisper some words containing the sounds ch and sh. For example, Spanish cherry. Normally, we do not hear these words except the sounds of th, sh, ch. In consolidation or inflammation of the lung, the whispered words Spanish cherry are heard distinctly.
Прошу казати. Шепотом, не голосом. Добре.
In this patient, all what we hear is s, sh, ch, and not Spanish cherry.